Hello everyone, and welcome to another series of clinical pharmacology. Today we are going to speak about anticoagulant. We have multiple group and drugs belong to the anticoagulant. We will learn about anticoagulant, a group of medication, about individual drugs. We are going to learn, understand, and apply the upcoming materials in the clinical practice. Understanding how the anticoagulant works, what are the consequences, what is or are the benefit of this medication, is there any adverse effect, and we are going to discuss some specific or special concern, such as pregnancy, for example. Let's dive in. So as you can see here, we have a case study for a patient, a 65-year-old male with a history of hypertension and hyperlipidemia. This patient current medication include aspirin, apixaban, amlodipine, atorvastatin. Aspirin 81 mg, apixaban 5 mg twice daily, amlodipine 5 mg once daily, atorvastatin 20 mg once daily. The patient complained, this patient admitted to the emergency department, suffered from chest pain, shortness of breath, diaphoresis, and the patient diagnosed with the acute myocardial infarction. So now the question mark for us, why the patient was already placed on the aspirin? What is apixaban? What is the purpose of atorvastatin? What is the purpose of amlodipine? So in our lecture today, we are going to answer these questions. I am Dr. Hassan, Associate Professor of Clinical Pharmacology and Clinical Research. Okay, before we start in the clinical pharmacology and drug information, we need to maybe learn a little bit about physiology, pathophysiology, what happened in the blood vessels when we have damage in the blood vessels. We are already familiar with the antiplatelets. Antiplatelets is a topic already covered with the previous lectures, and the link will be on the description for the antiplatelet. So I recommend you to review the antiplatelet before we go in depth with this anticoagulant lecture. So what happened here after the primary platelet glut? So we have primary platelet glut. Okay, the next step will be formation of fibrin platelet glut. So you can see here we have the final, this one considered like stable and hard thrombosis. Okay, so what happened here? We have the collagen fiber. We have the platelets release the mediators. Okay, after all these process happened, what happened here with when the platelet maybe demonstrate adhesion, activation, and aggregation to the damaged site, they start connecting and touch with the collagen fiber, and this will lead to the activation of coagulation factors. So this will lead to the activation of coagulation factors. At the end result of this activation will be convert of prothrombin to the thrombin. And prothrombin is like factor 2, thrombin is factor 2A, which mean activated. So this what happened here, we have thrombin, then the thrombin will enhance conversion of fibrinogen to fibrin. So this process here, the fibrin responsible for the final glut or stable final glut. Moving to the next slide. So as you can see from the previous slide, we have the activation of coagulation pathway. So we have coagulation pathway. We have two main pathway for coagulation, and this is responsible for producing of fibrin mesh. So we have intrinsic pathway, we have extrinsic pathway. The intrinsic pathway start from activation of factor 12 to the 12A. Then 12A will activate factor 11 to 11A. 11A will activate factor 9 to the 9A. Then factor 9A activate factor 10 to the 10A. So this is the important one here, the important maybe target for us, the 10A. This is the 10A, factor 10A, activate prothrombin to the thrombin. So 10A factor activate prothrombin to the thrombin, and in turn the thrombin will be enhanced conversion of fibrinogen to the fibrin. That means here the fibrin glut. So this is the intrinsic factors. What happens with the extrinsic factor? They said extrinsic factors start from factor 7. Factor 7 will be activated. Factor 7 activated factor 7 will enhance conversion of factor 10 to the 10A. Will factor activated factor 7 will activate factor 10. So this maybe like simple way to demonstrate two pathway for the glutting factors. So we have two pathway, extrinsic and intrinsic factors for the coagulation pathway. Okay, again, if you go a little bit and to the next step, what happened? As we already covered, we have intrinsic, and then we have intrinsic, extrinsic, and the end result will be activate factor 10 to 10A. 10A will activate prothrombin to the thrombin 2A. So what happened there in our body, in the human body, we have something called antithrombin, antithrombin 3. This antithrombin, you can see it here. This is maybe the schematic image or picture for the antithrombin. And that the antithrombin, we can read the text when we apply it. So what they said there, in a human body, antithrombin, this is available in the human body, inhibits several clotting factors, and most importantly, factor 2A and 10A. So we have antithrombin. Antithrombin, it's available in every human body, and this antithrombin activate factor 2A and 10A. Okay, what happened in this case? Antithrombin, the function of antithrombin will be slowly interact with the thrombin, will slowly inactivate factor 2A and 10A. So this is you can see it here, the antithrombin, this antithrombin here, slowly inactivate factor 10A and 2A, kind of compensatory mechanism. So we are all in the agreement here. In our body we have thrombin process, we have antithrombin process or antithrombin process. So this one is available in our body to protect from thrombosis. So we have two main pathway. We have thrombin, we have antithrombin 3, and we have balance between these two group of maybe substances inside our body. We have thrombin responsible for thrombosis, and the glut we have antithrombin to protect. Okay, moving to the next. First medication considered like anticoagulant will be heparin. Heparin bind to the antithrombin 3. Okay, we have antithrombin 3 here, and result in rapid inactivation of coagulation factor 2A and 10A. I will go back to remind you what happened there. So in normal process, antithrombin 3 works slowly. So you can see it here, works slowly to inactivate factor 2 and factor 10A and 2A. This is a normal process, physiological process. When you prescribe heparin to your patient, heparin bind to the antithrombin and accelerate, okay, inactivation process. So you can see it here, heparin bind to the antithrombin and accelerate inactivation factor 10A and 2A. So this is a mechanism of action. The question now, what is the mechanism of action of heparin? So a mechanism of action of heparin binds to the antithrombin 3 and rapidly inactivate coagulation factor 2A and 10A. Moving to the next slide. Okay. On the other hand, we have another group of medication called low molecular weight heparin. Low molecular weight heparin, the abbreviation here. We have two medication for low molecular weight heparin. We have enoxaparin and deltaparin. Enoxaparin, deltaparin, they said these two medication complexes with the antithrombin and inactivate factor 10A, but does not bind avidly to the thrombin 2A. So what we have here, if you let me say, like to think about that, enoxaparin inactivate factor 2A by, for example, 90 to 95% inactivation of factor 10A, but inactivation factor 2A could be like 10 or I would make it like 8 to 10%, for example. So this group of medication, enoxaparin and deltaparin, mainly bind to the antithrombin and mainly inactivate a thrombin or factor 10, factor 2A. As you can see here from the graph, low molecular weight heparin bind to the antithrombin, and this will be accelerate inactivation of factor 2A and weakly inactivate thrombin, which means 2A. So I will repeat this one. Low molecular weight heparin, enoxaparin, deltaparin bind to the antithrombin 3 and accelerate inactivation of factor 10A with a weak avidity to the thrombin 2A. So the question, what is the mechanism of action of low molecular heparin? What is the mechanism of action of enoxaparin or deltaparin? Okay, moving to the next. So we already discussed heparin, how the heparin work. We discussed the enoxaparin, number 2. Now we have medication number 3, fondaparinux. Okay, fondaparinux, this medication prescribed injection. Also the same situation. I will talk about heparin only briefly. Heparin given IV or subcutaneous, enoxaparin subcutaneous. So now we move to the next medication, fondaparinux. What happened here? What's the difference between heparin, enoxaparin, and fondaparinux? Fondaparinux, another medication. Fondaparinux considered like selective inhibitor factor 2, factor 10A. I will repeat it. Fondaparinux is a selective inhibitor of a factor 2A, selective. If you go back to the enoxaparin, it's not selective. Like the majority of effect on factor 2A, but it has some effect on 10A. Moving to the fondaparinux, they said fondaparinux selective inhibitor for 10A, and this medication prescribed subcutaneous once daily. Let me bring some pictures here for some products. I will share the screen with you with the Google Images. Okay, this is a heparin. You can see the heparin like injection. Okay, available as injection. Moving to the enoxaparin, this medication available as unit. And this is the enoxaparin pre-filled syringes. Then the fondaparinux injection available like 7.5 milligram enoxaparin injection, and if you can see this medication prescribed subcutaneous. Okay, moving to our lecture again, back again to our lecture. Okay, So we already discussed three medication with you. So we have here number 3, 1, 2, and this is number 3, fondaparinux. And this one subcutaneous. So the different, this one affect factor 2A and factor 10A. This one affect factor, what happened there? Go back. Okay, factor, what do you think here? Fondaparinux. This one XA. This one go to the fondaparinux again. Okay, number 2, mainly number 2A, and a little bit of, I'll make it small, 10A. So we have 3 medication already covered according to the how this medication work. We are discussing here mechanism. We are discussing mechanism of action. Okay, moving to the next medication, a group of medication. We have list of medication belong to the oral. So we have selective, number 1 selective, number 2 oral, and number 3 inhibit factor XA, 10A. So which medication prescribed orally and selectively inhibit factor 10A? We have 4 medication in this list: apixaban, rivaroxaban, betarixaban, and endoxaban. So we have 4 medication as you can see on the list: and apixaban, rivaroxaban, betarixaban, and endoxaban. How this medication work, as you can see from the name, if you like to remember the name, selective, this is the important things: oral, could be tablet or capsule, selective inhibit factor 10A. If you like to remember 10A, you can see here apixaban, we have XA, rivaroxaban, we have XA, betarixaban, we have XA, endoxaban, we have XA. So this group of medication prescribed orally and by inhibit selectively factor 10A. Okay, selective inhibitor, selective oral inhibitor of factor 10A. So the question: which of the following medications selectively inhibit factor 10A and given orally to the patient? So we can bring case study, and at the end of the study, we maybe ask which of the following medication prescribed to your patient upon graduation, maybe discharge from the hospital. This medication, they said, prevent stroke and atrial fibrillation, prevent and treatment of DVT, deep vein thrombosis, pulmonary embolism. Those should be adjusted, and the patient with renal failure, bleeding still the major concern or side effect of this medication, because this medication prevent coagulation. Okay, I will bring some picture for this one, for this group of medication. So you can see here apixaban tablet, okay, apixaban, and the brand name Eliquis. Okay, and another name, rivaroxaban, and Exaritro, rivaroxaban tablet, also available in 10 milligram, 20 milligram, rivaroxaban. Okay, so 2 medication available oral. We already reviewed with you: apixaban, rivaroxaban, endoxaban, and this medication work by selectively inhibit factor 10A, and this 2 medication prescribed orally. Okay. So we're done with the maybe now how many medication we covered already? Around 7 medication. Next we have direct thrombin inhibitor. Direct thrombin inhibitor, that mean inhibit factor 2A. Thrombin stand for 2A. Factor 2 activated factor 2. So thrombin mean activated factor 2. We have a group of medication that inhibit factor 2. So we are talking about medication inhibit factor 2. Now the question for you: give me a medication inhibit factor 10A, and this medication selectively inhibit 10A, and this medication prescribed orally. Okay, so we need to answer this question. Give me medication selectively inhibit uh, 10A and prescribe subcutaneous injection. So the question, I will leave it for you to answer it because we already covered in the previous slide. Okay, so before we move to the what we have later on, so we have two type of direct thrombin inhibitor, factor 2A. We have univalent thrombin inhibitor and bivalent thrombin inhibitors. Univalent mean binding to one site. Bivalent binding to the two site. Okay, on the thrombin. So when we talk about thrombin, so univalent direct thrombin, we have argatroban, dabigatran. Bivalent direct thrombin, we have bivalorudine, disoridine. So two medication here. We need to remember we have two group of medication. Univalent, we have argatroban, dabigatran. For the bivalent, we have bivalorudine, disoridine. Okay, so regarding the bivalents, this medication bind to the active site on the thrombin, the active site of the factor 2A. Argatroban direct inhibit to the thrombin. It can be used for alternative to the patient suffer maybe placed on heparin, but the patient due to the patient reaction, the patient suffer from thrombocytopenia. We call this one heparin-induced thrombocytopenia. You can imagine you place your patient on heparin. Okay, but the patient back to the hospital or back to the clinic suffer from HIT, heparin-induced thrombocytopenia. So you stop the medication. We stop the heparin. Okay, stop the heparin and switch the patient to the argatroban. Argatroban prescribe IV. Now, if the patient, for example, discharged from the hospital and you are going to put the patient on something oral, the result will be prescribed dabigatran. So dabigatran, this one in the patient in the hospital, argatroban. When the patient discharged from the hospital, we need to prescribe anticoagulant. The drug will be dabigatran. Dabigatran alternative for the heparin in patient with the history of heparin-induced thrombocytopenia. So you can see here we have alternative. We have approach for patients suffer from HIT. The approach will be argatroban IV when the patient in the hospital. When the patient discharged from the hospital, we cannot prescribe heparin again. The alternative will be dabigatran oral. Okay. So now we have the first group of medication. We need to understand how this medication work. So you can see the argatroban, dabigatran bind to the active site of thrombin 2A, bind to the active site of thrombin. Okay, moving to the slide to understand how. Okay, this is a thrombin, the molecule of thrombin. We have three sites. We have three sites for this one. You can see we have active site. We have exosite for binding with the fibrin. Then we have exosite to bind with the heparin. So we have three sites on the thrombin. The active site, and then fibrin binding site, heparin binding site. This is the thrombin molecule. Okay. Okay, we need to remember this molecule to move to the next one. As you can see here, we have argatroban prescribed IV. Argatroban binds selectively to the factor 2A, which means thrombin, and inactivate. The result will be inactivate or inhibits thrombin. Argatroban, the same similar mechanism of action. Argatroban prescribed orally, bind to the active site and inhibit the thrombin. So the same, we can type it here. The result will be inhibit thrombin or factor 2A inhibition. Okay, I will type here argatroban Okay, to see the what we have there for the argatroban. Okay, so you can see the argatroban available argatroban injection here, argatroban. And what about the other medication? For example, we have dabigatran. Okay, dabigatran here, or go to the image. Okay, dabigatran available oral. You can see it like a tablet here. Okay, dabigatran. If you click on this one, for example, dabigatran, oral pellets, Bradexa. So this one tablet and this one injection, and this medication considered like selective thrombin inhibitor, oral selective. We have oral, we have IV. Okay, moving to the bivalent direct thrombin factor 2 inhibitor, bivalent direct thrombin inhibitor. This medication, two medication, bind to the active thrombin site, bind to the active and bind to the exosite, which mean this exosite may be specialized in fibrin binding site. So this group of medication bind two sites, the number one active site, number two exosite. We have two medication. We have bivaloridine and disoridine. Disoridine. So what happened there? This medication, can we use this medication? The answer yes. We use it for patient with angina, unstable angina, undergoing percutaneous transluminal coronary angioplasty, BTCA. We can use it for patient at risk of thrombocytopenia. So for HIT, we have option. So we have argatroban, we have dabigatran, then we have bivaloridine and disoridine. So we have four options for patients suffer from HIT, heparin-induced thrombocytopenia. If you click on this link here to read some information about the, okay, so the medication here, bivaloridine, we can read it together. Bivaloridine for injection, intravenous use, bivaloridine IV. You can read the information here. I'll make it bigger for bivaloridine in order to make everyone able to read the information about bivaloridine for injection. Okay, so Angiomax, bivaloridine used for unstable angina and patient with the undergoing percutaneous coronary angioplasty. And the next we have it here, you can read it. This we prescribe to the patient at risk of heparin-induced thrombocytopenia. So we have two cases could be prescribed. Okay, so we have bivaloridine. This is IV. What about disoridine? Do you think disoridine the same? Disoridine. Go to the image. Okay, this you can see it here like injection, pre-filled syringes. Okay, disoridine. This one is like alternative for patient with the HIT or unstable angina or angina. Okay. Okay, moving to the next slide. This slide, the purpose of this slide to show you mechanism of action of disoridine and bivaloridine. As you can see here, this group of medication bind to the active site in addition to the exosite. This site is designed for the binding to the fibrin site. So we have bivalent action here for the bivaloridine, disoridine. Two sites, active site and exosite. Okay, this summarizes the information for us. We already covered. We covered fundabarinox, selective factor 10A, given subcutaneous, but and considered like selective. Apixaban, rivaroxaban, endoxaban, selective oral factor 10A, prevent stroke and atrial fibrillation, prevent and treatment of deep vein thrombosis, pulmonary embolism. Those need to be adjusted in patients with renal failure. Bleeding still the major risk. The bleeding will be the major risk for all these maybe medication or drugs. Okay, moving to the direct thrombin inhibitor. Direct, we have argatroban, dabigatran, and here we can add another group of medication on this list here. We can add bivarodine, and disaluridine, or disaluridine. So two medication here, we can add it to the market, and we already covered in the previous slide. Okay. Briefly again, this category for what we have one medication left for us to finalize, but we already covered heparin, low molecular weight heparin, fondaparinux as a mechanism of action or action. We covered the argatroban, dabigatran, rivaroxaban, apixaban, endoxaban. Okay, so we start with the first group of medication here. With the main group of medication, heparin. Heparin is considered like strongly acidic. Okay, because of the presence of sulfate and carboxylic acid group and negatively charged. Okay, so for this reason here, heparin is strongly acidic and negatively charged. For this reason, we don't prescribe heparin orally. So we have two reasons: strongly acidic and negatively charged. And for any medication, in order to be absorbed, need to be two things: need to be weak acid or weak base to be absorbed from the GI system. Number one. Number two, the medication need to be uncharged in order to be absorbed. So this one for the absorption, we talk about absorption. Any medication need to be absorbed from the GI system. We have maybe simple conditions: weak acid or weak base to be absorbed and uncharged. Here, if you look on the heparin strongly acidic and negatively charged. This is two things. Okay, low molecular weight heparin mainly replace the use of heparin in the clinical setting. Here we need to emphasize on this: heparin prescribed IV or subcutaneous. Low molecular weight heparin subcutaneous. They said never ever prescribe heparin intramuscular because this will lead to the formation of hematoma. So please remember, intramuscular administration of heparin or low molecular weight heparin is considered like contraindicated. Please remember that it's not allowed to prescribe IM intramuscular because this will lead to the hematoma. So we can prescribe, for example, here, I'm not sure if we are able to do something in the Google image. For example, we can type here okay, you can see here we have some cases of hematoma on the skin. Okay, so we have hematoma, some hematoma also here. So another one, this is coming from the injection of heparin, treatment with the heparin. Okay, so we don't prefer, it's not don't prefer, we prefer to say contraindicated, not allowed to prescribe heparin to the patient as intramuscular route of administration. So this is a question, very important question, in the national exam, local exam, or the maybe quiz or final exam. So which of the following, for example, prescribed to your patient? You will say, you are going to say heparin. What is that drug? What is the route of drug administration? The best route of drug administration of heparin or low molecular weight heparin? The answer will be subcutaneous or IV, not intramuscular. Okay. So we covered these two medications. Shall we compare? The comparison is very important. Heparin, 15,000 Dalton molecular weight 15,000, low molecular weight from the name 5,000, low molecular weight. Here we have, for talking about heparin, large molecular weight 15,000 Dalton. If you talk about low molecular weight heparin, enoxaparin, deltaparin, that's great. Low molecular weight. How this medication work? Speaking about heparin, heparin and bind and inactivate factor 2A and 10A. They said enoxaparin, deltaparin mainly inactivate factor 10. Activate platelets, yes, activate platelet. This one less activation platelet. When the heparin activate the platelet, the result will be or could be like HIT, and this explain the activation platelet to the cause of thrombosis. So the reason for heparin this maybe theories may explain why heparin may cause thrombosis or heparin-induced thrombocytosis related to the activate of a platelet. If you compare that with the low molecular weight heparin, less maybe incidence. Okay, the heparin could be prescribed to the inpatient, to the patient staying in the hospital, enoxaparin and deltaparin for outpatient. This is subcutaneous. The patient could be taken by himself the medication or herself, or could be through the nurse or pharmacist who maybe deliver this medication to the patient. So the patient could inject themselves with the enoxaparin. But for the heparin, this one should be IV, as we discussed, or subcutaneous. Therapeutic response, predictable. They said not unpredictable. Here we have maybe like fluctuation response. Here we have steady response. Bioavailability, 90% of the medication will be available in the blood. They said 20% of heparin will be available in the blood. The patient may frequently suffer from bleeding more frequently. If you compare with the low molecular weight heparin, less frequently. Half-life for the IV 2 and half-life for low molecular weight heparin 4. Titrating dose, do you need to monitor heparin treatment? Yes, we need to monitor by measuring the APTT, activated prothromboplastin. Not necessary. Even we have some maybe factors we can maybe measure it as factor 10A. So this table here compare between heparin and low molecular weight heparin. Okay, moving on to the next slide. Low molecular weight range, we discussed that. Specific for factors, more specific for factor 10. Molecular weight, high molecular weight, low molecular weight. Bioavailability, high bioavailability, low bioavailability. Half-life, 1.5 hour, 3 to 12 hour long half-life. Thrombocytopenia, common maybe common 10%, less common 2%. Bleeding, high risk of bleeding, low risk of bleeding. We need to monitor activated thromboplastin, tissue thromboplastin. Here we can maybe unnecessary, you can see it here, but we can monitor or measure the factor, anti-factor 10A. Okay, what is a side effect? Side effect, I don't prefer to use side effect, we prefer to use adverse effect or unwanted effect. Heparin may cause bleeding, hypersensitivity. Heparin may induce thrombocytopenia, HIT, or could cause liver abnormalities or osteoporosis with the long-term uses. So I will repeat it: bleeding, hypersensitivity, HIT, liver abnormalities, osteoporosis. Okay, bleeding complications. The patient on heparin, patients start suffering from bleeding. So maybe the appropriate approach, if we have severe bleeding, excessive bleeding, to stop the medication and start prescribe protamine sulfate. So protamine sulfate considered like anticoagulant. antidote for patients suffer from bleeding induced by heparin. Okay, infused slowly protamine sulfate combined ionically with the heparin to form stable inactive complex. So the antidote protamine sulfate will bind to the heparin and inactivate heparin. So if you said this is a heparin here, for example, so our medication will be bind to the heparin, and this is protamine sulfate, bind to the heparin and inactivate heparin. Okay, so the antidote, if the patient suffers from bleeding, excessive bleeding, this could be managed by discontinue the medication and prescribe protamine sulfate. This is IV and prescribed to your patient to prevent uh, bleeding. Hypersensitivity reactions is because heparin, they said, is derived from animal sources. Therefore, patient may cause or may form the antigenic reactions. Patient may suffer from chills, fever, urticaria, or anaphylactic shock. So you can see the protamine sulfate injection here as antidote for the heparin overdose or heparin bleeding. Protamine sulfate. So we need you to remember, if the patient suffers from bleeding due to the heparin therapy, the antidote will be protamine sulfate. Okay, if the patient suffers from thrombocytopenia, which means decreased number of platelet, thrombocytopenia, decreased number of platelet. Okay, heparin may induce thrombocytopenia, serious condition, and this could lead to the bleeding, and this requires discontinuation of heparin. And the option here, the alternative, they said we don't recommend to prescribe low molecular weight heparin as alternative. It's not like option here. Okay, heparin can be replaced by another anticoagulant. I need you to give me a name. What do you think? Which medication could be prescribed for patient suffer from stroke and a history of deep vein thrombosis, and he has a history of HIT? What is the alternative? If you say argatroban, you are correct. If you say dabigatran, you are correct. If you say disoridine or bifaloridine, you are correct. So all these you are correct. So this is alternative for the patient suffer from HIT, heparin-induced thrombocytopenia. Okay, roughly we're done with all these. The last medication belong to the anticoagulant. We have vitamin K antagonist, warfarin. The warfarin warfarin belongs to the coumarin antagonist. Coumarin anticoagulants. Warfarin has narrow therapeutic index. And here we need to refresh our mind to give me a medication considered like narrow therapeutic index. Okay, I will say digoxin. What else? Phenytoin. What else? For example, we type here warfarin. Yes, we have it here. Carbamazepine. So all these medications consider like narrow therapeutic index, and we need to understand. I refer student to the pharmacokinetic to understand what that means with the narrow therapeutic index. But here that means we are very close. The effective dose, the definition for that mean warfarin. The effective dose of warfarin. The effective dose of warfarin is very close to the toxic dose. Any change in the this is the effective dose here. This is effective dose. This is toxic dose. So we need the patient to be in this range. We call this one narrow therapeutic window. For this reason, any change in the blood concentration, any change up or down. So if you're talking about up, we have toxic effect, toxicity. If you the drug concentration below the effective dose, we have sub-therapeutic effect. What that mean here, we have less effect. That mean if we prescribe less dose to your patient, that means the medication does not work properly and the patient may suffer from clotting. If you prescribe toxic dose or large dose of warfarin, the result will be bleeding. Okay, we can monitor the warfarin by measuring INR, which means measuring prothrombin. I refer students to know what is INR by referring them to the diagnostic testing course by measuring INR, which related to the prothrombin for the patient and prothrombin for the healthy subject. Warfarin inhibit vitamin K epoxidase reductase. Okay, so the warfarin inhibit enzyme called reductase. I will repeat it. Warfarin inhibit enzyme called reductase enzyme, and the enzyme called vitamin K epoxide reductase, and this will lead to the decreased formation of factor 2, 7, 9, and 10. So I will repeat it here. Warfarin inhibit vitamin K epoxide reductase. This will lead to the decreased formation of factor 2, 7, 9, and 10. So warfarin interfere with all these factors 1, 2, 3, 4. Warfarin peak effects take maybe delayed to the 72 to the 97 hours. Warfarin anticoagulant effect can be overcome by administration of vitamin K. Okay, warfarin, we use it for prevention of deep vein thrombosis, pulmonary embolism, prevention of stroke. Okay, prevention of deep vein thrombosis following the orthopedic surgery. So warfarin is very popular medications and considered like one of the best treatment of in the practice, warfarin, but at the same time, warfarin carry side effect risk of bleeding compared with other medication. INR stand, if you would like to understand what INR here, INR stand for International Normalization Ratio. Here we need students to work a little bit and look on what is this equation mean INR, so we can bring some information. If you click on this link here and open the information, here they give us maybe let us maybe read a little bit. You can see here warfarin, comadine tablet. This medication used for prophylaxis of treatment of deep vein thrombosis, pulmonary embolism. Okay, so reduction of risk of death in myocardial infarction, thromboembolic event. So all these consider like the therapeutic use of warfarin. On the other hand, we have, okay, so what we need you to look here, what we have for warfarin, contraindications. Number 1, pregnancy. Okay, pregnancy. Number 2, patients suffer from hemorrhage, bleeding. We don't prescribe warfarin to someone who is suffer from bleeding. Okay, warning here that this medication, warfarin, may cause tissue necrosis. We are going to have some maybe image from the tissue necrosis. So this is the tissue necrosis from the warfarin when you prescribe it to the patient. You can see the tissue necrosis here, dead tissue. Okay, tissue necrosis. I'll back to the slide. Okay. So here for the warfarin, as you can see from the beginning, this is coumarin anticoagulant, has narrow therapeutic index. We need to monitor this medication by measuring INR. This medication works. This is a mechanism of action. This medication works by inhibit factor 2, 7, 9, and 10. This medication could be overcome or use antidote. We use antidote for this medication, vitamin K, vitaminadione. This medication used for stroke, pulmonary embolism, deep vein thrombosis, and prevention of deep vein thrombosis following the surgery. If you go back again to the slide and type here mechanism of action. Okay, you can see one of these, for example, action here. I will click on one of these, for example. You can see here how this warfarin work. Warfarin inhibits the enzyme called vitamin K oxide reductase. We need this enzyme for the formation of several clotting factors. I'm not sure if you can see it here. So you can see here the warfarin responsible for the maybe degradation of several clotting factors. Okay, back again to the slide. So as you can see here is warfarin. We need you to remember the mechanism of action, how the warfarin work. Warfarin work by inhibit four factors by binding to the vitamin K oxide reductase. Mechanism of action, warfarin competitively inhibit vitamin K oxidase reductase complex. Biological half-life of vitamin K depends on the coagulation protein. Biological half-life. So we need to recognize or differentiate between biological half-life. We have something called the plasma half-life. So biological half-life means the duration of effect. Duration of effect. They said it lasts around 72 to 96 hours. Duration of effect. Plasma half-life, remaining in the plasma, they said around 3 hours. So we have totally different approach. If you click on this link here, okay, so I would like to go to the slide again because we need to understand the concept for the plasma half-life and biological half-life. Okay, so you can see from this slide here, for example, our medication warfarin inhibit factors 2, inhibit factors 7, 10, and 9. And you can see the half-life for this group of medication, 7 hour, 24 hour, 36 hour, 50 hours. So in this case, we are talking about long effect. So warfarin has long effect by inhibiting these factors. Okay. Okay, let me move to the pharmacokinetic for the warfarin. Warfarin highly bound to the plasma albumin, prevent diffusion into the cerebrospinal fluid, urine, and breast milk. So unable to cross to the blood-brain barrier, unable to arrive to the breast milk, but the situation, this medication cross placenta barrier. So for this reason here, it's considered like teratogenic. Okay, this medication readily crosses the placenta barrier. For this reason, this medication may cause phytotoxic, teratogenic. For this reason, we don't prescribe warfarin to the pregnant woman. Okay, it's not prescribed, not allowed to prescribe. High affinity to binding to the sulfonamide. Sulfonamide, when you talk about sulfonamide, this could be the diabetes medication or UTI, urinary tract infection medication. For example, when you speak about sulfonylurea, ureas medication, type 2 diabetes, this medication used for type 2 diabetes, or we talk about product or medication called Bactrim, which include sulfamethoxazole plus trimethoprim. So we have sulfa here. So the patient for example, the patient already on warfarin. Okay, so you can maybe imagine the clinical case. The patient already on warfarin for the deep vein thrombosis. You prescribe the patient on warfarin. Okay, for DVT. But during his maybe daily life, he starts suffering from urinary tract infection. And as a physician, you prescribe Bactrim to your patient. So what happened there? According to the situation, okay, so I will go back again for the whiteboard. Okay, we have protein. Let me say like this one here in the plasma. This is protein, plasma protein. Okay, so when you prescribe, for example, warfarin bind to the plasma protein. This is a warfarin binding to the plasma protein. Okay, then the patient suffers from UTI, and you prescribe Bactrim or Bactrim. Bactrim, let me change the color. You prescribe Bactrim to your patient, and this is a Bactrim here. Bactrim will remove the warfarin and bind to the receptor. What happened here? This is, we call this one displacement. Remove the warfarin from the protein. We know from the pharmacokinetic, when the medication M bind to the plasma protein, the result will be MB complex. So this one free medication, this one binding medication. So the free medication will be active and move freely and free from the name. The binding, you will be inactive. So now we go back again to the warfarin. When the warfarin displaced and removed from the binding protein, the free concentration will be increased. When the concentration of free warfarin increased risk of bleeding. I hope this makes sense for you. Okay, so what they said here, the drugs that have greater affinity for the albumin binding sites, such as sulfonamide, can display warfarin and lead to the increase its activity. Here we can type here bleeding. Okay. Warfarin will be found in the urine and feces as inactive metabolites. Again, they remind us here with something very important related to the drug-drug interaction. You can Google it on Google Image, for example. A lot of site interaction between the warfarin and maybe other medications. Therefore, it's very important to study the drug-drug interaction with warfarin before you place your patient on any medication, any other medication. Look on the warfarin prescription information to be sure there is no drug-drug interaction between warfarin and other medication. Bleeding, how to manage bleeding. If the patient suffers from minor bleeding, only withdraw the medication and give oral vitamin K1. That's fine. Minor, like epistaxis or like minor bleeding. When you have severe bleeding, such as in the brain or in the GI system, hemorrhagic stroke, for example, or like peptic ulcer bleeding, that require large doses of vitamin K, and we prescribe vitamin K IV. So we need vitamin K IV, but here is not enough, because when you prescribe vitamin K IV, this need time to be active. And you remember the half-life, we discussed the half-life with you, and this may take like several hours to start working. When you prescribe vitamin K IV to antagonize action of warfarin, we prefer to use it, but it take hours, and the patient come to the clinic, to the hospital, suffer from severe bleeding. When you have severe bleeding, okay, we go the blood transfusion, frozen plasma, or plasma concentration. So the best way to treat and rapidly reverse toxicity of warfarin will be blood transfusion, frozen plasma, or plasma concentration. The patient maybe suffer from necrosis, skin necrosis. We have seen the picture from the Google image. Also, we discuss this group of medication or warfarin considered like teratogenic and contraindicated during pregnancy. Okay, so for example, if you have woman and she is on warfarin and she is planning to have a baby, we stop warfarin and switch the woman to the heparin or low molecular weight heparin. So this is maybe a question in the exam. So the woman is already on warfarin and she is planning to have a baby, and what is your maybe management here? Keep the woman on warfarin? No, stop warfarin and switch to the heparin. That's correct. Okay. Okay, next we need to compare between the heparin and warfarin. What is the difference between heparin and warfarin? And I try to maybe focus on the highlight things, not everything on the slide. What is the difference between heparin and warfarin? Number one, distribution. They said heparin cannot cross blood-brain barrier, unable to cross placenta or blood-brain barrier. For this reason, considered safe in pregnancy. Warfarin can cross placenta and blood-brain barrier, is not allowed to prescribe during pregnancy. Mechanism of action, we discussed that. Heparin bind to the antithrombin and accelerate. Warfarin inhibit vitamin K reductase, inhibit several factors. Pharmacological action, this medication start 2 to 3 4 hours for the heparin, and this for the when you talk about warfarin need 8 to 12 hours to start working. Okay, treatment, we use heparin for maybe for treatment of established thrombosis. So you can see here we use it for treatment. Heparin used for treatment of established thrombosis. We use it for prevention of thrombosis. On the other hand, warfarin oral, heparin subcutaneous IV, heparin given orally, 2 to 10 gram for prevention and treatment of deep vein thrombosis, post-operative thrombosis, cerebral venous thrombosis, coronary thrombosis. Could be prescribed like adjunctive therapy for acute arterial pulmonary embolism, and anticoagulation is initiated by heparin and maintained by warfarin. How to monitor your patient with for the heparin, we go the APPT. For the warfarin, we measure the INR. The value will be 2 to 3 times the normal compared with the normal values, 2 to 3. If we have more than 3, that means we have risk of bleeding. Here we have bleeding for both of them cause risk of bleeding. The antidote for heparin will be protamine sulfate. The antidote for warfarin will be the vitamin K1. Okay, Side effect, we don't prescribe heparin IM intramuscular because risk of hematoma. Heparin may cause thrombocytopenia, HIT. Heparin may cause osteoporosis. Heparin may cause alopecia and dermatitis. All these side effects: hematoma, thrombocytopenia, osteoporosis, alopecia, dermatitis. Regarding the warfarin, hemorrhage, bleeding, skin necrosis, teratogenicity. Okay, during pregnancy increased risk of pregnancy by itself increased risk of deep vein thrombosis and pulmonary embolism. Use of warfarin in the first trimester associated with a 5% increased risk of fatal hemorrhage. So we don't prefer to use warfarin during first trimester. Neither heparin, low molecular weight heparin can cross placenta barrier and does not cause fatal bleeding or teratogenicity. For this reason, we prefer to use it for the pregnant woman suffer from risk of the thrombosis. They said we talk about the profile, safety profile. Heparin, low molecular weight heparin may cause osteoporosis if used through the pregnancy. So we have here safety profile. If you use it, if you use warfarin during the first pregnancy, first trimester, there is risk of hemorrhage, fetal hemorrhage. If you use heparin, low molecular weight heparin, there is a risk of osteoporosis. Okay, we done with the anticoagulant. We stop here for the maybe a break, few minutes, then we come back. Okay, so we already covered the anticoagulant. We spoke about the heparin, low molecular weight heparin, fondaparinux, argatroban, dabigatran, bivaloridine, warfarin, apixaban, endoxaban, rivaroxaban, all these medication, how this medication work, what is the risk, how you can deal with the bleeding, for example, for warfarin, or bleeding due to the heparin treatment. Now we move to the next section about thrombolytic drugs. Next topic, we are going to speak about thrombolytic drugs. Here we have patients suffer from thrombosis. Patients suffer from thrombosis or clotting. Okay, we need to dissolve this clot. So what we can use here in our system, in our body, we have something called the plasminogen. In our body, we have plasminogen. Plasminogen will be converted to the plasmin. Plasmin will be responsible for dissolving fibrin. So plasmin will dissolve the fibrin. Okay. They found two medication. We have 4 medication, but another 4 medication not available in the clinical practice anymore. Uric kinase, streptokinase, but this is the most popular medication now. Uric kinase, streptokinase. Uric kinase derived from the urine, and streptokinase derived from the bacteria. It's not in the clinical practice, popular clinical practice. What we have here, we have alteplase and tenecteplase. This is DNA technology production or products. So tenecteplase, alteplase activate conversion of plasminogen to the plasmin, and plasmin will be dissolve the clot. Okay, tenecteplase, as you can see here, tenecteplase, I said, is considered like recombinant tissue plasminogen activator. Recombinant tissue plasminogen activator, TPAs, prescribed IV, restoring catheter and shunt function by lysing and dissolving clot. This dissolved clot in the stroke and used for patients from acute thromboembolism disease, such as acute myocardial infarction, pulmonary embolism, and acute ischemic stroke. Patient in this case, when you have alteplase and tenecteplase, patient may suffer from risk of bleeding. So if the patient suffers risk of bleeding, how to can approach, what is the antidote here? Okay, we are going to answer this question later on. Adverse effect, we discussed the hemorrhage, bleeding, major adverse effect, how we can treat the patient. We have it in the next slide. It's not recommended to prescribe the alteplase, tenecteplase during pregnancy if the patient suffers from healing wound and brain tumor or trauma or like metastatic cancer. We don't prescribe, we don't recommend, or in other words, it's not allowed to prescribe tenecteplase to the patient with these circumstances. Okay, what we have here, we have the antidote. I like this one. Antidote for the bleeding. If the patient take fibrinolytic such as Alteplase, okay, the antidote will be tranexamic acid, aminocaproic acid. If the patient on warfarin and suffer from bleeding, the treatment will be vitamin K. If the patient on warfarin and suffer from bleeding, the treatment will be protamine sulfate. If the patient on dabigatran, what is dabigatran? This is oral selective factor 2A inhibitor. Dabigatran, drug of choice for patients suffer from HIT. And I hope you maybe remember HIT stand for what. Okay, if the patient suffer from bleeding due to the dabigatran treatment, okay, the antidote will be adirosuzumab. What is adirosuzumab? So adirosuzumab antidote for the treatment of bleeding due to the dabigatran. Aminocaproic acid competitively inhibit plasminogen activation. The same will be applied here. This medication may be used to stop bleeding due to the toxicity of a fibrinolytic. Could be used for some maybe ocular trauma or lung surgery. Adirosuzumab IV infusion. Adirosuzumab can be used as a rapid reversal of the anticoagulant effect of dabigatran. So that if you have uncontrolled bleeding or like urgent surgery and we need to stop this medication suddenly, the best option to go with the adirosuzumab to antagonize the action of dabigatran. Okay, this is a medication name. Adirosuzumab injection. Then I need to show you some aminocaproic acid. Aminocaproic acid as, okay, this is aminocaproic acid. Then we have tranexamic acid. Okay, available in both tranexamic acid injection and oral. Okay, that's it for our lecture today. Okay, for this lecture, we already covered the anticoagulant here. We start with like a brief review of the coagulation cascade. We have intrinsic and extrinsic pathway. Start from factor 12, factor 7, ended up with factor 10A. Factor 10A activate prothrombin to the thrombin. Then we have the fibrin as end product. We discussed the heparin. We discussed the mechanism of action of low molecular heparin, fondaparinux, and we went through the medication selectively inhibit factor 10A, such as apixaban, rivaroxaban, and other factors that inhibit 2A, such as for the 2A we have argatroban and dabigatran and other molecules. We discuss in detail warfarin, and at the end of this chapter we discuss fibrinolytic, talking about alteplase, tenecteplase, ended up with speaking about antidote, about this group of medication. Thank you for listening and have a great day.